we're here to go over some of the concepts of activating forces throughout all of the osteopathic manual therapy systems. So we've got a few different systems and a few different techniques, some direct, some indirect. So what we want to talk about first is the concept of, in whatever you're going to do, you need to have a diagnosis, you need to have an assessment. So we've talked about assessment concepts before, and you can find those other places either on the website or on the YouTube channel. Now, once you have your assessment, you have to choose, do I want to go direct or indirect? Direct essentially being the direction of bind, the direction of restriction. So if you were looking at something, when you move it, it will start to feel tight. You will put tension on it. So the palpatory experience for the practitioner is that it will get tight wherever you're touching, wherever you're paying attention to. If it was the knee and I moved the knee, the tissues would go taut, they would become tight. If you want to go indirect, the concept being that those tissues would essentially get soft, they would get squishy, right? Or you're going into the ease away from resistance. All of these terms end up being somewhat nebulous, but to go direct, tissues will get tight. To go indirect, tissues will go soft, okay? Now, our general activating forces we will speak about, regardless of system, what we have is patient active, so the patient moves. Now, within patient active, there's a lot of different ways to do that, and we'll briefly touch on that, and we have before. When you use that, you kind of have this overarching concept, which then has subdivided components where we would speak more about patient passive. Now, patient passive, it becomes easier to have the concept of compression, so squishing things together, tension, or distraction rather, tension's not correct, distraction, pulling things apart. So if we're looking at the knee, we have compression, pushing it together, distraction, pulling it apart. We have torsion, right, rotating things in relation to one another. And although it is not a pure movement in terms of the appropriate use of the term, we can have the concept of shear, so things moving in a linear fashion in opposing directions with respect to one another. So if I was looking at the knee and I stabilize the femur, in essence, it can pull the femur towards me, and I can push the tibia essentially away from me, and I get a shearing motion. So those are essentially activating forces. Now, if we just take a brief digression to have a discussion here about patient active, if I wanted to create patient active distraction, then in the case of the knee, what I can do is I can have the patient, so what I'm going to have you do is pull your hip up towards your ear. So go ahead and do that and let go. So because what I've done is I've essentially attempted to immobilize the tibia or the leg below the knee. As he pulls his hip up, I should get a distracting force. Now, if I hold at the heel, what I want you to do is try to push your heel into my hand and then let go. Okay? Then in essence, although I can't control the movement as well because of how hard the patient can push, which becomes more of a control issue, I have a harder time controlling because I don't know how hard the patient's going to activate themselves or how hard they're going to push. But if he pushes, as he pushed his hand or his heel into my hand, the knee should have gone into compression. If we look at torsion, right, rotating things in relation to one another. So if I wanted to, I could internally rotate, right, the tibia in essence, and then what I'm going to have him do, as I block, I'm trying to find a good hold so I can actually block him appropriately. I just want you to try to turn your knee out and then let go. So essentially what we get is that torsion. If I wanted to create shear, then it's harder to do, right? But if I want the leg to kind of go in opposing directions, I can push the foot inwards, and then I can have the patient, what I want you to do is try to push outwards at the knee, right, and then let go. So essentially we get that shear. So that is using those motions in and around the knee with respect to a patient active approach. The patient passive approach, again, we've already kind of gone over this with respect to the knee. Now in a lot of cases this is not an ideal setup. If I wanted to create distraction, I generally want to face the direction I want to go, or I want to face in line with it so that I can use less effort. But you'll see how I kind of bring my arm in and I can just lean my body and create the distraction. Now I can use my eyes as well as palpation to see if things are starting to come apart. One thing that I will say is my patients are always fully clothed. In some other jurisdictions, in some other countries, osteopathic practitioners will have their patients remove some of their clothing. In England, for instance, my understanding is that many patients may be in their undergarments. I'm not 100% sure about that, but that is information that I've heard from varying people. One of the things I want to say about that is that if your patient is fully clothed, their clothes can make you think things are happening, right? So you have to use both senses, so multisensory integration. So I can create my distraction, my compression, my torsion, and my shear. Depending on which joint I'm in, it may look different. The concept of relational motion comes into play here. One thing stays still, one thing moves in relation to it, or both things move in relation to one another. The decision-making process here becomes interesting. So once you have your diagnosis, you then have to choose, do I want to go direct or indirect, right? So if I wanted to go indirect on the knee, and we've already said this, my general overarching aim is to make the area soft. Now, to do this, what we want to do is consider all of our activating forces. So essentially, patient active as an overarching umbrella to create compression, tension, torsion, and shear, or some variation of those. So I may be able to use 2 or 3 of them together, depending on the situation, right? If I'm going indirect, I want to have an algorithm, or whether I'm going direct or indirect, I want to have an algorithm as to how I go through those. So the one that I will tend to use is, I will be monitoring the joint that I'm interested in. I'll create compression, see if it makes it softer, right? See if it makes the area softer. And if it does, I like it. If it doesn't, I don't like it. There's an ease or kind of low-hanging fruit as far as thinking that compression will make things softer, and it does not always. You will have to go through these on purpose to identify what creates tension or what creates softening of the tissues in the area. So I create compression, create tension, I can create torsion, and I can create shear. Now, if I was to say something in the case of this patient's knee, especially with where I'm palpating, the softness or the ease is actually distraction. Now, again, that may be cognitively counterintuitive, but this is why you have to pay attention. This is why you need to have an algorithm. So compression does not make it softer. Distraction makes it softer. Now I can check with that, torsion, and then we get some softening, and shear. There's really nothing from shear. So what I'm going to do on purpose, as far as creating softening in a patient passive situation, I've purposely went through an algorithm: compression, distraction, torsion, and shear. And I've identified for this patient's knee, if I'm trying to go indirect and create the ease, that I use distraction and torsion on some levels, right? They're smaller movements. If I wanted to go direct and I wanted to create, especially if we're looking more at the knee, if I wanted to create some tension in the tissues, then again, compression, distraction, torsion, and shear, right? I go through that algorithm. I identify on purpose which one or multiple of them provide the outcome that I'm looking for. So again, the algorithm for myself, and you can change this, it doesn't matter, but you need to have a clear-cut algorithm. You purposely go through compression, distraction, torsion, and shear to identify which ones provide you the outcome you're looking for. If you're going direct, you're aiming for increase in tension in the region. If you're going indirect, you're looking for a reduction in tension or softening, or in a very colloquial way, I can say, make it go squishy, make it easy. So we're looking at all of this as an overarching concept. So first, you require a diagnosis. However you come to that diagnosis, we've spoken about that before with assessment concepts. You find the area that you're interested in, you create the appropriate tests or appropriate motion tests. Once you've done that, you make your choice. Do you want to go indirect or direct? If you want to go indirect, it's more likely that you're doing it because there's more pain, whether acute or chronic pain. If you want to go direct, it's more likely that the motion dysfunction is accompanied by minimal pain. And the reason you're doing that is because you don't want to create much pain in the process for the patient. So you choose. You make your diagnosis, then you choose, do I want to go direct or indirect? Once you've chosen that, you have your overarching concept that for direct, I want to increase tension. For indirect, I want to reduce tension. And then you go through your algorithm as far as how you apply this. For me, it's compression, distraction, torsion, and shear. Then I can also, if some combination of those isn't working appropriately, I can make the patient active, right? My tendency is to avoid making the patient active because I do not know how much force they're going to generate. I can more appropriately create the amount of force that is needed, and I can be more attentive to it. It's not going to go too fast. It's safer, more controlled. But if you want the patient to become active, you still use that algorithm: compression, distraction, torsion, and shear, or whichever order you want to create for yourself. Once you've then applied your treatment, be it direct or indirect, using one or more activating forces, then your aim is to reassess. If you reassess and you have appropriate restoration or appropriate change of the motion dysfunction that you had found, you move on. If you haven't, right, so what you can do is, if the method that you used did not work, you can then change the barrier. So if you went indirect, you can then go direct. If you went direct, you can then go indirect. So that's an immediate option. Another option is to go and treat a motion dysfunction somewhere else in the body and then come back. And it may have changed based on time, or it may have changed based on some form of restriction somewhere else in the body being something that the body is compensating for in disparate areas. That's a concept that's very difficult to measure, very difficult to identify. It's at least a possibility, but if for nothing else, then the time spent away from the initial motion dysfunction that you're treating, you may get a positive result just because you leave it alone. So that's also a possibility. And we talk about the concept of temporal correlation, where just because two things happen at a similar time doesn't mean they're related in any way other than time. So if I'm treating the knee and it's not working, I went indirect on it, I went direct on it, it's not working, I move on to the neck for some reason, or the shoulder for some reason, I come back and all of a sudden the knee's better, it might just be because I left it alone. But again, we come back to the overarching concept. The overarching reason for this video is as far as utilizing activating forces. So you need a diagnosis. Once you have your diagnosis, you can choose, do you want to go direct or indirect? Then when you do choose direct or indirect, you go through your algorithm as far as compression, distraction, torsion, or shear, figure out which ones give you the appropriate outcome in the area that you're working on. And then once you've finished your treatment, you reassess. Now, patient active can be in there, and you can start to mix and match these. However you mix and match them, do it clearly, in an orderly fashion, and on purpose.